Hello, everyone. Welcome to today's live broadcast, the Cure Educated Patient Webinar in CLL. I'm Christy Call, Editorial Director of Cure. We're pleased to bring you this webcast presented by Cure and in partnership with the Leukemia and Lymphoma Society. We have a few important announcements before we begin. We encourage you to ask questions during the event, which you can submit by typing them into the Q&A box. You will be receiving a survey via email tomorrow. As a thank you for watching the full webinar and completing the survey, you will be entered to win one of 3 Visa gift cards. We are pleased to be joined today by our moderator, Dr. Carrie Rogers, Assistant Professor in the Division of Hematology at The Ohio State University Comprehensive Cancer Center, Dr. Danielle Brander, Assistant Professor of Medicine at the Duke Cancer Institute, and Ms. Jill Verschell, Supervisor of Advanced Practice Providers at the University of Texas MD Anderson Cancer Center. Thank you for joining us today, and I will now pass off to Dr. Rogers to begin the discussion.
Hi, I'm really excited to be having this discussion today and to be joined by Danielle and Jill. To open the discussion, I think a really nice topic to start is just ways in which chronic lymphocytic leukemia is now a chronic disease and how patients can live longer and actually live better now, both on observation and with active treatments. To start, I was just going to ask Danielle and then after her Jill to say a few things that they really like about taking care of patients and kind of the long-term aspects of that for their CLL patients.
Sure. Well, thank you, too, for inviting me and for everyone that's participating today. I think really what I'm privileged to be part of a team that helps care for patients with CLL is, as you mentioned, that both enhanced treatment for the CLL itself, but hopefully also a better recognition of the teams that can help care for a patient with CLL. And what I mean by that is for patients living hopefully long and healthy lives, how do we best partner with their primary care team? How do we better learn from the patient and their caregiver needs? How do we employ nutritional services? So I think from the chronic part of that, certainly the advances in treatment that can be better tolerated are helpful, but also as we better learn how to use some of the supportive services. And of course, lastly, I'll just say that I think all of us learn so much from patients and their caregivers, what works for them, what doesn't work for them. So in today's world, just trying to be flexible to patients' needs and learn from them ultimately.
And I'm very happy to be here as well. I work as a physician assistant with Dr. Bill Weirda at MD Anderson. And so as his PA, it is my role to do a lot of the coordination of care and to help patients through managing both side effects related to treatment as well as some of the other chronic conditions that our patients tend to have. And so it is, it's exciting to see it turn into something that we can look at long term and have discussions with patients about how to keep themselves healthy and how to manage around their treatment with their eye on a much longer term course of their disease. It also means looking forward to any potential changes in therapy as their disease may progress and may lose response to therapies. We have a much broader array of treatment choices available. So planning ahead for that as we start to see patients either lose response or go off and then need to go back on treatment.
Thanks. That's I wanted to add my 2 cents on this too. I think since CLL is the most prevalent adult leukemia, meaning more people are living with CLL than any other, it affects a lot of them. And so CLL has affected them during the course of their life in both states is really important because having CLL means different things to different people. So Jill, since you were mentioning taking care of people like longer term and also some supportive care aspects, Is there anything you've noticed for patients in observation that really affects their quality of life or is common that you need to address in that patient population?
Well, one thing we always emphasize with our patients is that even if their disease is well controlled or in remission or whatever the status may be, they still are technically immunosuppressed. And so we try to be very vigilant about things such as staying up to date with vaccinations. We talk to patients about making sure they have both pneumococcal vaccinations, the Prevnar 13 and the Pneumovax 23. And we are now recommending that patients go ahead and get the new shingles vaccination, the Shingrix. We're still lacking data on the efficacy of the Shingrix vaccination as far as preventing shingles in immunocompromised patients. So we have a discussion with every patient, and depending on their history of having shingles and their willingness to be on prophylactic antiviral medication, we may make a different decision on that. But we also try to emphasize just taking good care of themselves long term, to be mindful of the other things that may be going on in their lives that they need to be watching for. So managing their hypertension, managing their diabetes, all of those things become important as patients grow older and are on therapies that may make those issues worse. And so making sure that we're staying on top of managing all of those various conditions.
How about Danielle, have you noticed any kind of like symptoms of CLL that people even in observation live with? I've noticed fatigue a lot in some of my patients.
Yes, I think building on what you've talked about is how we help patients, even if by what we say the traditional reasons that we start therapy doesn't mean that patients won't have any symptoms from their CLL. So I completely agree with you. I think one of the most common things is fatigue that can be related to the CLL. Sometimes in getting to know patients, knowing how that impacts their life, but also looking and being open-minded for clues that there might be something else going on. So what I try hard to do is obviously to help provide the best care possible for managing their CLL. And even if they're not in therapy, things like they're being at risk for infections or at risk of other complications, but also recognizing that we should look for other things. So if they are having fatigue, occasionally you find the iron deficiency or you find something else. So also being open-minded to look for other causes besides the CLL. But I'd say, yes, by and large, it's a very hard conversation because I certainly recognize that the fatigue can be life changing for patients that are used to being very active, but trying to find what is the level that they can manage versus what is the level that might be indicating something is changing with their disease or that we have to look for other causes. I will say that it's also hard in terms of fatigue because if you don't find something else other than some modifications, how do you help patients with that fatigue? We've tried doing a lot of work with our colleagues in exercise interventions and other fitness plans. Our cancer center also separately than the studies will try to work with patients for a exercise or activity plan, because I do think, though it sounds counterintuitive to exercise more when you're tired, that can make a big difference, but it's very hard in our time together with patients to say, start exercising. That's not very much of a plan. I think we have to help better to tailor our recommendations for the individual patient and follow back up with them.
Boy, that's really great, because I take care of a lot of people who struggle with chronic mild fatigue that I think might be related to the CLL, but it's not enough that I think treatment would necessarily improve it. I'm going to have to consider the exercise intervention. Also, I'll add that I diagnose probably more people with sleep apnea a year than cancer-related fatigue. And I feel that there's always kind of on the part of patients, once you have something that is as serious as a cancer, you tend to think that all your symptoms are related to this thing, which sounds like scary. And part of it is really just sitting down with someone, talking to them in detail, and then figuring out if what they're experiencing is even, potentially related to the CLL. I also recently had someone who was having a symptom with exertion of shortness of breath, and actually ended up being related to their heart disease that we got straightened out, but they were very sure it was related to the chronic lymphocytic leukemia. So I also think that's a really, really important part. Well, as we know, not only is CLL chronic, but now with our newer treatments, several of these oral targeted agents, like ibrutinib, which is Imbruvica, and acalabrutinib, which is Calquence, are now chronic treatments. So people get side effects from them over, years that they take them. And there's always the serious ones that you read about, like atrial fibrillation, which is an abnormal heart rhythm, or high blood pressure, which puts you at risk for cardiovascular events. But Jill, have you noticed any side effects that patients are living with that are maybe not as serious but impact their lives?
I'm sure. I think one question that has just been raised is the issue of having brittle fingernails, which sounds like a mild thing, but when it's happening to you, it can be very annoying at the very least. So things such as brittle fingernails, muscle aches, joint pains, these are common enough that we're pretty sure they are associated with the ibrutinib. Once we found that once we get patients at a therapeutic dose and get a good response, that we can safely dose reduce. And so this is why it's important to have regular contact with your physician. And if you notice things that just are abnormal or new or you haven't had before, it's worth discussing if it could be related to the ibrutinib or the acalabrutinib, Imbruvica or Calquence, whatever treatment you may be on, to just see if a dose modification might improve those symptoms to where you can continue to take that treatment and live with it.
I've seen some people that were helped by biotin for the nail changes and some that were not helped by biotin. It seems to be hit or miss. I've also seen some people that just had things that they found irritating that weren't enough to stop a treatment that tended to change over years of taking it without explanation. And I'd love to say why that happened, but I just don't know. Something else we just got asked was if there's a relationship between chronic lymphocytic leukemia and risk for blood clots like deep vein thrombosis or a pulmonary embolism. And as people may or may not know, cancers in general are associated with a higher risk of blood clots. However, the type of cancer matters greatly. So pancreatic cancer is associated with an extremely high risk of blood clots, but most large studies where it's been looked at, chronic lymphocytic leukemia is associated with only a very small increased risk of blood clots. So it does seem to increase the risk some, but not as much as the majority of other cancers when it's been looked at in large numbers of patients. And I think something related to that too is how blood thinners are handled, because those can be a long-term treatment for people, and so can both the BTK inhibitor medications, ibrutinib or Imbruvica, and acalabrutinib or Calquence. And so trying to keep people on both together can be challenging, especially because both Imbruvica and Calquence seem to have a higher risk of bleeding or bruising, or combinations with anticoagulation. So I was going to ask Danielle if she had any comments about how she successfully has people on anticoagulation taking those drugs, or what she tends to do in general.
Sure. Yeah, no, absolutely. Definitely a complicated area in terms of patients with CLL or SLL and risk for bleeding, as you mentioned, at baseline. So before starting acalabrutinib, Calquence, or ibrutinib, Imbruvica, patients don't necessarily have a higher risk of clotting. There are some studies that suggest maybe some individual patients might even be a little prone to bleeding, but I think the big takeaway is that there's a lot more that has to be understood in that area. For patients that either are already on a blood thinner or have a reason to start a blood thinner, when on ibrutinib or acalabrutinib. The way that I approach it is what is the reason that they have to be on it? And so, for example, if patients otherwise are young and fit and don't had one episode of atrial fibrillation, which is an abnormal beating of the top part of the heart, and it happened once when they were sick, and I talk with the cardiologist, they might not feel patients' risk from that is high enough that they need to be on a blood thinner. And if that's the case, then we just don't start the blood thinner when they're on ibrutinib or acalabrutinib and raise the risk. If the cardiologists or whoever feel that patients do need to be on a blood thinner while they're on medications such as ibrutinib or acala, then I try to lower the risk of everything else. So maybe they need to start the blood thinner, but I pretty strictly recommend against Coumadin or warfarin. I don't have any patients on that blood thinner plus ibrutinib or acalabrutinib because it's a higher bleeding risk. We look at all the other medications, so try not to also be on aspirin or drugs like Plavix. And look at supplements too. I think that's where our pharmacists help a lot. So the bottom line is try to minimize the risk as much as you can so that you're down to truly, if you need the blood thinner, and often picking what has the lowest risk, which are some of the oral or by mouth direct blood thinners versus Coumadin or warfarin, which have a higher bleeding risk.
Great. Yeah, I gave you one of the hard questions. So I didn't want to answer that one, so I thought I'd let Danielle do it. Since we've been talking so much about BTK inhibitors, I thought we'd just move into a discussion about them, just so I could catch everybody up a little bit about what they are and how they work. So the BTK inhibitors are oral pill treatments that bind to and block a protein called BTK, which stands for Bruton's tyrosine kinase. So BTK is a very special protein because in CLL cells, it allows a signaling cascade to let their CLL cells grow and continue being CLL cells. So taking these drugs really makes the CLL cells behave a little bit unusually at first. Like you'll see a lot of them go into the blood when you start it. And then it really controls the CLL over time. So it's something that people have to take for multiple years of treatment. So it's a long-term treatment. But in several studies comparing it to chemoimmunotherapy, which is chemotherapy with an antibody medicine, people actually were alive and without the CLL coming back for longer, so did better with treatment when they took these BTK inhibitors. So there's two of them that are FDA approved for the treatment of CLL. There's ibrutinib, which is marketed as Imbruvica, and then acalabrutinib, which is the drug Calquence. And they're really neat because they actually work in the same way. They bind to and block and inhibit BTK. They bind the protein at the same site. So they have the same mechanism. Acalabrutinib is more what we call selective, meaning it blocks BTK, but doesn't block as many other proteins in the mix there, because no drug is perfect. So we don't have anything that just perfectly targets BTK. There is another BTK inhibitor that works in the same way called Xanabrutinib, which is approved for mantle cell lymphoma and has been studied in CLL. And then a whole new exciting group of BTK inhibitors that actually block BTK using a different mechanism from Imbruvica or Calquence. So I think those are going to be really exciting, and they're currently in clinical trials. So that's kind of the technical parts of it, but I don't want to minimize how much this class of drug has improved the lives of our CLL patients by providing treatment with a once or twice daily pill that works better than IV chemotherapy and generally has side effects that are different, but for the majority of people, easier to live with than side effects from chemotherapy. So this kind of class of drugs has really improved the lives of people with CLL, I think, a great deal. So this was a huge thing for people living with CLL, but you never get anything for free. So like everything, it comes with its own set of drawbacks. But I do think this was a very important class of medication. And then extra important for people that have CLL with high-risk features, meaning cytogenetic kind of changes in their CLL cells that predict that chemotherapies won't work for them. these oral targeted agents work very well to control the CLL in those cases and have been huge for those patients. And I don't know, to move the discussion forward, maybe Danielle could let me know who she thinks the group of CLL patients where BTK inhibitors are best used in, or when she would consider prescribing a BTK inhibitor, either Imbruvica or Calquence for somebody.
Sure, and this follows up with the difficult question you asked me in the last segment about risk for bleeding. As you pointed out, these drugs go after that BTK protein in the cancer cells, but that can also be in platelets, which help with clotting, which is why we can see the risk for bleeding. So in terms of choosing among treatment options when we meet with patients when they do definitely need treatment for the first time, as you mentioned, for most patients, chemotherapy from these studies is not the best first treatment. So then we're talking about treatment with either the Ibrutinib or the Acalabrutinib as BTK inhibitors. There are other non-BTK inhibitor treatments that we won't get into as much today, but venetoclax. But for patients for BTK inhibitors, one of the things about Ibrutinib and Acalabrutinib is they can be started at whatever their starting dose is. And for the most part, initially, patients can do well. So you can talk to patients ahead of time. They start taking the pills and they come back a week or so later to check in and how to see how they're doing. It can work very quickly on people that have symptoms related to the lymph nodes, so the glands in the neck or under the arm or in the groin being large, or if the spleen is large. So for patients having a lot of symptoms related to that, it can these treatments can make those symptoms a lot better because the lymph nodes in the spleen can get much better, and then usually takes a couple of weeks, but blood counts, so if blood counts are low, can come up. For patients where it might not be the best first treatment, or at least we have to talk a lot longer, are patients that do have to be on a blood thinner or multiple things for blood thinner, maybe have a lot of cardiac history or cardiac concerns, and then we just have to talk through if that's the right treatment. But I think from lots of the clinical trials, it has been a benefit for many patients. But trying to summarize this in 2 minutes when often I spend an hour at least with patients is a bit challenging, but I think you summarized it very well.
I actually think selecting a first therapy for people with CLL is the longest amount of counseling I do during any patient visit.
Mm-hmm.
It takes a long time to go through BTK inhibitors and really the other approved alternative, which is obinutuzumab and venetoclax. Certain high-risk PDLL, like specifically deletion 17p, there might be an advantage to taking a BTK inhibitor such as Imbruvica or Calquence compared to obinutuzumab and venetoclax, which is Gazyva and Venclexta. And this really is based on data from when they've given the drug to a lot of people, where you see that with the Gazyva Venclexta, people deletion 17p seen that with our BTK inhibitor and for a high-risk patient. Did you have something to add, Danielle?
Oh, I think your audio had just cut out, so I was just going to summarize what you're going to say, which is what we do as well, which is for patients with the highest risk 17p, we do tend, unless they have a reason not to start with BTK inhibitors, or of course clinical trials if patients are able to participate in those.
I completely agree on clinical trials. So I was hoping maybe Jill could tell us something she's noticed using BTK inhibitors for patients, both some things she noticed that were really good about this class of drug, or anything that she's noticed that is a drawback that her patients have told her.
Well, you mentioned that these frontline treatment discussions tend to take the longest, and I would agree with that. I think one of the important things is to make sure that patients understand what to expect when they go on these therapies. Sometimes patients like the idea of a short but intensive round of treatment, more like the traditional chemoimmunotherapy, FCR or BR treatments we used to give as the majority for frontline. And so patients need to understand that when they start treatment with an oral therapy like a BTK inhibitor, it's a long-term treatment, and compliance is really, really important. They also need to understand what to expect in terms of side effects. It's very common to have some GI side effects, such as loose stool or maybe a skin rash early on, but those side effects usually do resolve with time. And so helping patients to expect that and how to manage it rather than be surprised by it and want to just stop therapy. So we want patients to try to keep going if the side effects are manageable, to keep going and try to work through them, and hopefully they will resolve or improve with time, and try to get that maximum initial response. Also educating patients to expect the rise in the white count. So if a patient is starting treatment, they already have a high white count, it's only going to get higher, and that's okay. It doesn't pose a risk. The high white count, the high lymphocyte count does not increase the risk of clotting. And so helping patients to understand and expect that is another part of that initial conversation.
Thanks. I think that was really well put. We have a question about whether or not we know what the long-term side effects of acalabrutinib or Calquence are compared to ibrutinib or Imbruvica, is how I would frame it. We've had ibrutinib probably, I think, like 7 or 8 years now, going back to the clinical trial experience. So we don't, and acalabrutinib or Calquence is a few years behind that. So we don't really have like a decade of experience with either of these drugs. So it depends on what you mean by long-term. But I personally think we do have long enough experience with Calquence or acalabrutinib that we can say quite a bit about the side effects that occur over years of taking the drug. I don't know if either of you agrees with that statement or has anything to add about differences between Calquence and Imbruvica.
I think as you summarized, I would agree that having several years of experience and also the number and hopefully diversity of patients that have taken those treatments is enough, meaning patients that have had chemo and treatment before, and Calquence, acalabrutinib is their 4th treatment versus patients receiving it as the first time. There's now been a lot of patients to receive it on clinical trials and longer to be able, hopefully, to counsel patients on what to expect and what some of the differences might be between the two medications. I will say where I think it is really important, though, to directly compare them and say long-term what the side effects. Ideally, we look for clinical trials where within the same trial, half of the patients got one of the medications like ibrutinib and half got acalabrutinib, because then you have similar group of patients where you can say this is the percent where the side effects were similar between the drugs, and this is maybe an area where they're different. And there were trials like that have happened. And so when they reach long enough follow-up, then I think we'll have even more information to be able to tell patients.
I'm personally very excited to see there's a randomized phase 3 trial, which is where a large number of people are assigned to either Imbruvica, which is ibrutinib, or Calquence, which is acalabrutinib. And the goal of the study is to look if there's any differences in effectiveness, but I'm very excited to see the side effect profile of both those drugs side by side. We have a question in the chat I would like to address. So someone has asked us, if you're unable to be in a clinical trial, what standard of care available drugs are there for people who are resistant to Imbruvica, so people with CLLs come back while they're taking it? Venclexta or venetoclax has been used really effectively in this setting. So there's a specific study looking at venetoclax or Venclexta taken after ibrutinib, and it's more effective than any other drug that I'm aware of that's currently available or marketed so that you don't have to get it in a clinical trial. So that is a very good standard of care option for people who are resistant to Imbruvica. Acalabrutinib or Calquence, because it has an identical mechanism to ibrutinib, which is Imbruvica, should not be used after Imbruvica and will not be effective in this setting. And we've actually demonstrated that. So you do have to switch classes of drugs. And venetoclax or Venclexta is the one that has the most evidence behind it right now. So I wanted, since we're talking about differences between BTK inhibitors and then we were talking about venetoclax or Venclexta a little bit, I think it's really important to talk about differences between oral therapies or IV therapies and then the meaning of chemotherapy. And I know that Jill had some comments she really wanted to share on this that I thought were great, and this is something people ask me about all the time.
Sure. So I just wanted to clarify some of the terms that you'll hear used. There are oral therapies or targeted therapies like we've been discussing, Imbruvica, Calquence, Venclexta. Then you'll hear the term immunotherapy, which can refer to some of the newer treatments that are not yet approved for CLL, but can also include what we call the monoclonal antibodies, such as rituximab, or Rituxan, ofatumumab, and the third generation version is obinutuzumab or Gazyva. And while those are IV therapies, they are not technically chemotherapy. So when you hear talk about how we're post chemotherapy for the most part in CLL, that still doesn't mean that you may not be recommended to receive an IV treatment, and that IV treatment would most likely be one of the monoclonal antibodies. So there's a little bit of confusion just because of the way that the terms are interchanged. But chemotherapy, when we talk about treatment for CLL, refers to the classic chemotherapy drugs such as fludarabine, Cytoxan, bendamustine. And those are still appropriate for a very limited number of patients, but by and large, most physicians are moving away from chemotherapy, but are still utilizing the IV treatments such as Rituxan and Gazyva. So that's not confusing enough, then we can try to add some more terms in there for you.
Yeah. I've definitely had patients that told me that were like moving from somewhere else, that coming to see me for the first time, like, oh yes, I got a bunch of IV chemotherapy and like X time, and then I got their treatment records and it turns out that they've gotten a monoclonal antibody, which is very different than an IV chemotherapy, but it is an IV treatment. So I think as a patient, it's always important that you understand these differences, even though it's an IV medicine, in terms of what you're getting, and always try to ask, your healthcare team for all the information about what it is that you're going to take as a treatment. So I talk to my patients about it. The nurse practitioner I work with talks to them, and our specialty pharmacists actually spend some time with our patients describing to people their treatments, and that can be really helpful for them too. I do have a couple people that don't want to know anything about their treatment, but I think that's the minority. And so I just think also feeling like you should ask questions about what you're getting either in an IV or as a pill is really important. So I've had people that were confused about their medication when we told them, oh no, I know that's a pill, it's not a chemotherapy, it's like this oral targeted agent. They were even more excited about taking Imbruvica because now they understood what it was. And so I think that's an important thing to know. So I guess for Danielle, is there anyone that you still think should get IV chemotherapy, or where that might be a good choice? Or what do you think about when you consider that for someone with CLL?
So I think in general, across the board, not just chemo, but anything, more options, though it makes for longer discussions, is always better, because for all the patients we see in a given year, there might be some patients where they come into the hospital and they need something readily available and very quick acting, and they don't have a high risk marker inside their CLL, and they can get started right away, and you don't want to, for some reason, use antibodies. The first principle I would say, though, is always do no harm, and do no harm in the short term, but also in the longer term. So I need to know enough about their CLL to know that giving like the markers inside the CLL, for example, that getting started with that treatment right away is better than waiting and getting all the information and going with targeted therapies. So to answer your question, I think it's getting to be a smaller and smaller group of patients I would consider for chemotherapy. They have to have the favorable markers, not just the FISH like you mentioned, but a different marker called IGHV. So I think, though we won't get into all the details of what we test for inside the cells, that's a really important one to ask for if you're being considered for chemo, because if patients have the unfavorable unmutated, we know from the clinical trials that chemo is definitely not better. So to answer your question, it has to be the right situation. Patients have to have favorable markers, and there has to be a specific reason that we want to get started and use the chemotherapy. And it very, very unusual would be to ever use it for patients that need treatment after the first treatment. So I can't think of the last time. Before, we used to talk about different chemos. People would get it their first course, then the CLL would come back, they'd get a different kind of chemo. Really, we have enough options that as second treatment, it definitely really isn't being presented. Sometimes as first treatment for a fit patient with favorable markers, I'll include it as part of the discussion, but to be completely honest, it's getting to be a smaller group of patients. I'm also beginning to think that you're throwing the impossible questions my way. But more options is better because we want to be able to give patients the best treatment for them.
Yeah. Okay, I'll have to take the next hard one then myself since I gave you that one. I completely agree with everything you say. The only thing I would add is that sometimes when you get CLL that has, and then people go on to develop a different type of cancer, specifically lymphomas, which is something known as Richter syndrome, a fraction of those can be actually cured or eliminated completely with a sort of unpleasant course of IV chemotherapy. And I've had some patients that are like, oh, but I was told not to get chemotherapy. I'm like, okay, but we might actually cure this other type of cancer with it. So for people that have other forms of cancer, even though they have CLL, it might be appropriate to take an IV or oral actual chemotherapy agent for that part. Well, I think that detailed discussion for that last hard question moves us into our last topic, which is really about shared decision-making, or what factors you like to use to help make decisions with patients about treatment or anything else that affects their CLL. Like, what do you want to know about them? What do people usually have on their mind? And I was going to ask Jill to tackle that first, or what concerns she likes knowing about patients, or what she thinks really adds to those conversations.
Sure. So one thing I would add at this point is, in the era of COVID, which looks like we will be in for a while, it adds a new dimension to shared decision making. And it's so important to involve the caregivers. Right now at MD Anderson, we have a no visitor policy. So patients are having to come to their appointments alone. And it's very challenging for patients to take in all the information and to make a decision without their caregiver there with them. So one thing that's very important for us, especially if we're discussing treatments, is to involve the caregiver, either get them on the phone or get them on FaceTime so that they can be involved in that discussion. And as we discuss the options, we have to take everything into consideration. So not only what is the best treatment from a medical standpoint, but also what is feasible for the patient. What is it going to involve? Can they do a clinical trial, or do they live too far away to be able to make all of those visits? And what type of laboratory monitoring is going to be needed to follow them as they start treatment? Also, what is the cost of the treatment? These oral therapies are incredibly expensive, and there's a lot of patient assistance available, but the majority of our patients who have CLL are on Medicare, and that really restricts the financial assistance that they are eligible for. So we have to work very closely with the specialty pharmacies to see what their copay will be and factor that into the decision making as well.
Yeah, that's a good point. And actually, good financial assistance for people with high copays is available. And sometimes going through that process of trying to get grants or additional assistance to help with a high copay or selecting treatment based on that can be incredibly stressful for people. So I actually usually start talking about financial implications when I first start talking about treatment. So just because it's such a part of the discussion. I also wanted to add or say something along the lines of what you were mentioning. So I live in Columbus, Ohio, which is I think the 14th or 15th largest U.S. city now, depending on like which poll you use. And so I grew up in the Chicago. I agree that this is a big city, but a lot of my patients live in rural areas that feel this is a very big city, and we have a very big medical center here. The parking is very complex, and we do have a few roles where people can have a visit or an appointment, but mostly they can't. And the number of appointments people have with COVID and also, before COVID makes a big difference. There are people coming from rural areas that driving to appointments in the infusion center is a huge deal. And, there's kind of two frontline treatment options that are discussed a lot, which is the BTK inhibitors, either Imbruvica or Calquence, or a combination Venclexta-Gazyva, which is given for only a year. And I've had a lot of people that wanted to take, the Venclexta-Gazyva one because they thought, okay, that's 1 year, it'll be shorter, but it requires a lot of visits to start. One for infusion visits for the antibody medicine, and then to safely start Venclexta requires a lot of monitoring visits. And I've had people that really could not take on the challenge of coming that many weeks in a row for visits and selected a different treatment just because that was very unsuitable for their life. So I think talking about the administration schedule or what they'll have to go through to start or continue taking a medication matters a great deal. And then I've had some people that don't, I can come every day you want, no problem for me, but it matters to me how long I'm going to take it. And I find until I've discussed some of those things with people that I don't really know what's most important to them, and I don't like assuming those things. So I don't know, I think that's actually very interesting, especially when I didn't realize how stressful it was for some people to come to Columbus because I didn't really see it as a big city, and I park at the medical center every day, which also is very stressful for physicians too. Let me just put that out there. Our parking's being remodeled. But, those are things that if I hadn't asked, I never would have known. Okay, can I give Danielle a chip shot question then? Do you want an easy one? Someone has asked us what criteria are moving from watch and wait to treatment since we've discussed it so much.
Yeah, no, I think that's really good. And just what both of you said to echo is, trying to find out what's important to patients and that, and their caregivers and what is feasible. So the important question of what moves patients from either watch and wait, or sometimes we say dynamic or active surveillance, to meeting treatment indications. We generally follow what's called a consensus guidelines, meaning those that have looked at reasons patients should start treatment and put together in a set of guidelines are called the International Working Group CLL guidelines for looking at reasons to start treatment. And patients don't have to meet all of those reasons to start treatment. And there also might be a gray zone where you think you're moving to treatment and need a little bit of time to see if truly it's needed. But generally, I tell patients those reasons for treatment most of the time fall into three main categories. One would be symptoms related to the CLL that have some of the things we talked about before, like fatigue or night sweats or lots of weight loss that's moving from being manageable to really impacting quality of life that you have to treat, and it's due to the CLL. So that's one reason, not usually the only reason. The second kind of main area that sometimes requires therapy is if the lymph nodes or the spleen are progressing and either causing symptoms or are reaching a size where you really need to start treatment to prevent complications. And then the last main reason for treatment is if the CLL is impacting on the blood count. So everyone has CLL in the bone marrow, which is the factory where our blood cells are made. So if it gets so crowded or impacts on those cells, then the hemoglobin, which is the red blood cells, can fall. That's called anemia, or the platelet number can fall. That's called thrombocytopenia. So if the hemoglobin's in the 10 range or falling or symptomatic or platelets less than 100. There are other less common reasons, like if people have autoimmune conditions that are impacting blood counts or otherwise can't be controlled, then sometimes you have to treat the underlying CLL. There are rare reasons to start, but those are the main reasons, and those fall under the guidelines. Generally, CLL, I tell patients, it usually doesn't change quickly, and that's why we set up the follow-up appointments the way they are, because our hope is to tell patients we see things progressing and moving in that direction. You don't yet need treatment, but there's usually a warning. It doesn't usually happen suddenly that those things fall off. So those are the main things that we look for to move towards treatment.
I think towards talking about shared decision-making and kind of a question of how patients can better communicate with their medical team, one important thing is to tell people what they're experiencing, if they're worried about it or not. Like sometimes people will come and say like, oh, I've noticed I have a grape-sized lymph node now. Does this mean I have treatment? Because you said large lymph nodes could mean I need treatment. And, you know, it's a very small lymph node that isn't really going to cause a problem and isn't a sign that someone needs treatment. So bringing up things that are on your mind, whether or not it's something that we need to act on, is really important. And then also we talked about fatigue a little bit before, but I was taking care of someone that was too tired to do the dishes, but didn't tell anyone this. And also like had other signs that the CLL needed treatment, like decreases in blood counts and so on. So if you don't bring things in your daily life to the attention of your medical team, then, you know, we can't help you address those and figure out if there's something that is important or isn't important towards needing treatment. The other thing that I kind of wanted to add about shared decision-making or how to communicate with your medical team is really just if there are things in your life going on that are going to affect what you're doing with your medical care or, you know, stuff in general, definitely say so. So if you're thinking of moving, like retiring and your health insurance is changing, I am not very good at explaining how to select new health insurance, but I know some people that can help with those things. And, you know, or if you've developed a new medical condition, or if you have taken up golf full time, I don't know, not that golf matters that much for selecting a treatment or anything else, but these are really important things, I think, to know about someone. So I always like spending a few minutes talking to people about what's going on in their lives. And I find that helps me do better determining how to, you know, take care of them, when to see them back, and so on. So
Yeah.
I always like that. And go ahead.
Oh, yeah, I was just going to say, I also think we're trying to summarize things here briefly, but our hope is over having the time to meet with patients each visit to answer questions, and it'll start meaning different things to you with time. So when you're first diagnosed and have all this information, it's really hard to know how to put that in the right context for you. So it's also okay to ask the same questions each visit, or some of the same questions, because they'll start to mean different things to you the longer you have this. It's overwhelming to put it in context when you're hearing it all at once. The other thing in terms of shared decision-making that I try to individualize with patients is how they make decisions, because I never, and what information is helpful, because I also don't want it to be overwhelming. And I've realized, you know, some some patients, it is totally fine to want to hear the high points and then to hear a recommendation from your treatment team. For other patients, they truly wanted a dialogue and then time to think about it and make the decision. Some patients want a couple opinions, and that's okay too, and then they ultimately make the decision. But I think in that shared part, just be honest about what's most helpful to you to make that decision, and don't ever feel like you're going to make the wrong choice. Because if I thought there was a completely wrong choice, then we wouldn't include that in the list to talk about.
Well, I'm going to let Jill share her thoughts on just closing thoughts on shared decision making, and then we're doing general Q&A. And I think the first question is really hard, so I'll do that one. To be fair. But...
Sure. The only thing I would add at this point is to echo what you both have said. And what we like to do is when we start to see that a patient is nearing the point of needing treatment is to, if we were seeing them every 6 months, maybe see them in 3 months, maybe see them in 1 month. And as we see that we're getting near that point, lay out some options, have that discussion, and bring them back after they've had time to think about things, do some reading, talk to whoever they want to talk to, and then they can come back with more questions, and then we can, at that next follow-up visit, agree on a treatment plan at that point.
Okay, well, I think we're going to take some general CLL questions, and the first one that was asked is, how is CLL caused? And I think that's an outstanding question, but an extremely difficult one. So I was going to tell you kind of my view on this in general terms. So as we know, all our cells in our body are made from parent cells or stem cells that divide and are replaced over time. So, you know, your skin cells slough off, your hair grows, your blood cells actually turn over continually over your lifespan and are the fastest dividing or the most dividing cells over your lifespan. So CLL is a cancer of a type of immune cell called B lymphocytes. And what happened was sometime over the lifespan, as the parent or bone marrow cells divide and make more B lymphocytes and the cells divide and grow, they make an error. Most cells that make an error just die, but some of them break or make an error in a way that causes them to become CLL cells. So it's actually a mistake that is made that causes them to be broken cells so that they're leukemia cells instead of healthy cells. There are influences over your life that make that more or less likely to happen, that they'll break in that way. For an example, the Veterans Administration considers Agent Orange exposure a risk factor for CLL, probably because it makes the cells in some way more susceptible to be breaking in a way that makes them CLL. So I don't have a, like, this is what causes CLL. It's just an inherent part of being alive and having cells that divide, that the B lymphocytes sometimes break and become leukemia cells. And then environmental and other factors can influence kind of the risk of that happening. Okay, well, I think the next question's for Danielle. I think someone wants to hear more about your comments regarding dynamic versus active surveillance and kind of what the differences are there, or why you describe it that way.
Sure. I think, or I hope, in feedback from patients, that the classic term watch and wait is hard because of the wait part, and also it just sounds like we're going to check things along the way, and maybe doesn't reflect what Jill brought up, which is it's a dynamic process. One visit might be a month later to follow up on things, so it's a dynamic, changing way. So I just meant that active surveillance, you're being active in watching it, not just necessarily waiting for something to happen, because some patients it might not. And also that process isn't just checking in at regular intervals. It's adjusting the recommendations of how frequently we see patients, what tests we get, depending on what happens at that visit. And so trying to tailor it to the individual patient. So I've just heard a lot of terms to try to replace the term watch and wait to more reflect what we do, which is adapt that to the individual patient. So
I think that's really well put. I've been going with observation, but I'm not sure that's better. Jill, I know you're at MD Anderson. Do you want to tackle this next one about CAR T treatment in CLL?
I will take a stab at it, but only to say that it is still very experimental. It is definitely a kind of an option that we would reserve when we don't have many other options available. We have not seen a whole lot of success so far, and we would, it would not be our top recommendation. The difference, I think, between choosing CAR T over stem cell transplant, traditional stem cell transplant, is that for CAR T to be effective, you have to have active disease present, whereas stem cell transplant, a patient needs to be in remission. So it depends on kind of where the patient is, what other options we may have, whether we would consider either CAR T or CAR NK, which is natural killer cell. We do have trials available with both of those, but again, these are still considered very, very last ditch, so to speak, treatments at this time.
Yeah, I thank you for that. I agree, and they are treatments that are improved compared to when I first saw them being studied, years ago. So we are getting better at them. But these fall in the category, so traditional donor stem cell transplant, CAR T cell therapy, CAR NK cell therapy are all in a category of cellular therapies, meaning you're getting infused with living cells that are going to attack your cancer, hopefully. And it's a group of therapies or treatments that are appropriate for people that are generally pretty healthy, but also people with more advanced or severe CLL, because they, especially the CAR T and CAR NK, are investigational or experimental therapies, and really for people where you don't have these other options to do non-experimental therapies with good results. And I actually think we have safer, more effective oral targeted agents in clinical trials for the majority of patients. So this is for a very select group of CLL patients that aren't expected to benefit from non-cellular based therapies.
Yeah, and I would just echo the saying that it's promising technology in that you're shifting directions and trying to think of other ways to engineer those cells to go after the leukemia cells. But like a lot of things, including in trials, always trying to balance the risk versus who needs the benefit from something different. And so far, most of the trials are actually designed that the trials aren't available, certainly not as a first treatment, and usually not even as a second treatment unless patients have specific risk disease or criteria. So for some patients, we've seen really good success, but then the question is for others that don't respond, how do we find the patients that need it the most, that can respond? How can we make the technology better and safer? And then, like a lot of things asked earlier on, what is the long-term follow-up? So how long for patients that get response will that last? So I think for some patients, it's been very promising because it's a different direction, but how can we make it better in trials?
Yeah, and I've personally seen some people with CLL that benefited greatly from cellular therapies, but you kind of have to fall in the right category where that's the best thing to help you, because the majority of people I see with CLL are benefiting from oral therapies, even those that are getting them in clinical trials. But I think Danielle's correct. In the correct group, it can be amazing, but you really have to select carefully for who's going to benefit from that. All right, so next question is there such a thing as CLL remission? Do you want to handle that one, Danielle? Trying to give you easier ones now.
Yeah, I think it's great because we use sometimes these terms that can be very confusing, especially if you know someone with non-CLL cancer, where we use terms like remission or response. I personally try to use the word response to say if it was treated, how it's responded to treatment, because my concern with using the word remission, while it might be true that treatment has knocked things down, a lot of times with CLL, you are watching to make sure that it doesn't come back. And that, of course, depends whether you're on continuous therapy or between treatments. So there might be a such thing as remission, but I at least try to explain and be specific with patient what kind of response are they in and what are we watching for. That doesn't mean, though, that responses can last years and years and years, whether you're on treatment or not. So others might term it differently. But.
Yeah, well, I think there's formal criteria for remission or not, but whether or not that applies to an individual might not really matter to them, because if they're taking an oral targeted agent, doing well, feeling well, and living their lives, what kind of remission label you put on it isn't necessarily something like when you give a defined chemotherapy, you say, oh, you're in remission, and this is never coming back. In a chronic disease like CLL, that's not really, something that is necessarily as big a part of the conversation. Okay, well, unfortunately, we are out of time for today, even though I've really loved this discussion with Jill and Danielle. If you'd like to watch this webinar on demand, it will be available on curetoday.com/webinars, and I think it's going to be posted in the next few days. I definitely want to thank my other two panelists, especially since I gave all the hard questions to one of them. So I really appreciate them doing this with me today. And I really want to thank the audience for attending and participating in today's events, because the three of us are really doing this for you guys in the I'd also like to thank Cure and our partner, the Leukemia Lymphoma Society, for making today's educational webcast possible. Don't forget to check your email tomorrow for a survey to be entered to win a gift card. And I'd like to thank you all for joining. We'll see you next time.
Bye-bye.
Bye, guys.